Endometriosis prior to IVF, to touch or not to touch. Endometriosis is a leading gynecological problem encountered in up to 10% of the female population. Fertility problems are very frequently associated with endometriosis. Unfortunately, the field of assisted reproduction has opened a wide channel for achieving pregnancy in patients with endometriosis. Management of endometriosis prior to IVF is a subject of debate and controversy, and there is conflicting evidence whether to perform a surgical procedure for endometriosis prior to IVF or proceed directly for the procedure. The classic thinking of, when in doubt, cut it out, has been replaced with a more evidence-based approach that tries to balance carefully the advantages as well as the complications of cyst removal prior to ART. The following practical points should be taken into consideration in management of endometriosis prior to IVF. There is convincing evidence to support the responsiveness to gonadotrophins after ovarian cystectomy. There is convincing evidence to support that responsiveness to gonadotrophins after ovarian cystectomy is reduced and the number and quality of oocytes retrieved are not improved even with best surgical procedure. Surgery is not free of complications, especially that the majority of patients selected for IVF have advanced stage of the disease and probably had a surgical procedure before. According to a meta-analysis, the rate of major and minor complications associated with laparoscopy is 1.4% and 7.5% respectively, and it should be noted that major complications include bowel injuries and ureteric injuries. Surgery is not free of charge, and in terms of cost-benefit analysis, surgery is an additional cost prior to IVF. Moreover, surgery may be associated with longer days of stimulation and more gonadotrophin requirement. Standard stripping technique used in laparoscopic removal of ovarian cysts may be associated with higher spontaneous pregnancy rate and lower recurrence rate, yet reduces ovarian reserve and the number of oocytes retrieved per ovary in IVF. The coagulation or the vaporization technique, which entails opening the cyst and coagulating or vaporizing the bed, may be associated with better results in the preservation of the ovarian cortex, yet recurrence rate is higher in comparison to the standard stripping technique. Ultrasound-guided aspiration of endometriotic cysts with or without injection of sclerosing agents seem to be the most acceptable solution in this dilemma. Aspiration versus cystectomy, no difference in clinical pregnancy rate. Moreover, aspiration is associated with better ovarian response and higher number of mature oocytes retrieved. However, aspiration is associated with higher rate of recurrence and is considered and a considerable instance of pelvic inflammatory disease, especially when sclerosing agents are injected. Finally, and in conclusion, it should be noted that classic surgical procedure for endometriosis, cystectomy or cyst ablation, is still considered in 4 clinical scenarios. Clinical scenario number 1, endometrioma more than 4 cm, especially when interfering with oocyte retrieval. ممكن تبقى endometrioma أكتر من 5 سم وتتساب, so long it's not interfering with oocyte retrieval. Unilateral endometriomas, especially in young patients with good ovarian reserve, and the decision for IVF is still questionable. دي أكتر عيانة على فكرة بتستفيد بالovarian cystectomy. Endometriomas associated with severe pain, here surgery and medical treatment may improve the clinical condition prior to IVF. Clinical scenario الأخراني, endometriomas associated with sonographic pictures suspicious of malignancy. Thank you.